Welcome, everyone. Thank you so much for joining us today. My name is Jillian McConnell. I'm the Knowledge Translation Specialist with Brain Exchange. And on behalf of my colleagues from the Canadian Coalition for Seniors Mental Health, also known as CCSMH, we welcome you. We're so pleased that you're able to take part in this webinar event. A few housekeeping items to get underway, before we get underway rather, with today's presentation. So the audio is provided via your computer speakers, so please ensure that your speaker icon on the top of your screen is green and your volume is high or to the level that you're most comfortable with. On the top corner of your screen, you'll find a Q&A box. If you have a question about the webinar, please type into the Type Here section of the Q&A box and hit Enter, and that's how you can communicate with me and my colleague during the presentation. I do want to note that only the presenters and I can see your questions, not your fellow participants. And this box will appear throughout the webinar, and it's also where you can send your questions during the Q&A portion of the event, which will take place during the last 15 minutes or so. A copy of the slides from today's presentation, as well as the actual guidelines themselves, will be made available through the links posted at the end of the event. These links will also be located within the event listing on the Brain Exchange website. The presentation itself is being recorded, so within 2 to 3 business days it will be up on the Brain Exchange website within the archived events section, and all participants will receive an email in their inbox notifying them that the recording is ready. We do encourage you to pass on that link to any colleagues who weren't able to join us today. And if you have any technical issues, we ask that you respond back to the confirmation or reminder emails you received, or you can just email to webinars@brainexchange.ca. You can see the little email address hyperlinked in blue in the Q&A box, and we'll be able to assist you via email. So for all intents and purposes, those are the major features you need to be familiar with. And so now it is my pleasure to introduce our topic and our presenters. So the title of today's session is Canadian Coalition for Seniors Mental Health and Clinical Practice Guideline for Assessing and Managing Behavioral and Psychological Symptoms of Dementia, and features our presenters, Dr. Dallas Seitz and Dr. Jennifer Watt. Dr. Seitz is a professor of psychiatry and community health sciences in the Cummings School of Medicine at the University of Calgary. He is the scientific director of the Provincial Addiction and Mental Health Program at Alberta Health Services, co-chair of the Canadian Coalition for Seniors Mental Health, and immediate past president of the Canadian Academy of Geriatric Psychiatry. His research examines health service and knowledge translation in geriatric mental health. Dr. Seitz is actively involved in the development of health system strategies, guidelines, and policies related to seniors and mental health at both the provincial and national level. Dr. Jennifer Watt is a scientist at the Knowledge Translation Program, a geriatrician at St. Mike's Hospital, Unity Health Toronto, an assistant professor in the Faculty of Medicine and the Institute of Health Policy, Management, Evaluation at the University of Toronto, and an adjunct scientist at ICES, the Institute for Clinical Evaluative Sciences. Dr. Watt completed medical school at the University of Ottawa, internal medicine residency at Western University, and geriatric medicine residency and PhD in clinical epidemiology and healthcare research at the University of Toronto. She has received a number of awards for her scholarly activity, including the 2019 CIHR Institute of Health Services and Policy Research Rising Star Award in 2021, the Outstanding Junior Research Manuscript by the American Geriatric Society in 2021, the University of Ottawa Faculty of Medicine Rising Star Award, and the 2023 Excellence in Research Award for the Medicine Program at Unity Health Toronto. Dr. Watt's research focuses on improving the quality of care for older adults. She uses knowledge synthesis and health administrative data to better understand the comparative efficacy and safety of pharmacologic and non-pharmacologic interventions in older adults, specifically those with geriatric syndromes such as frailty, falls, and cognitive impairment. She also implements research on older adults into clinical practice and supports the development of clinical practice guidelines. So I'm so thrilled to have both of these presenters with us today. On behalf of everyone on the line, we welcome you. And Dr. Watt, I believe you're getting us started, so I'll turn the floor over to you.
Okay, great. Thank you very much, Jillian, for that introduction, and thank you everybody for being here today. So we just have some disclosure slides to get started for Dr. Seitz. So, and I should say also myself, but my disclosure slide is coming next. We both received an honorarium from the CCSMH to support the development of this guideline. Dr. Seitz also has received a financial payment or honorarium from Alberta Health Services. You can see there he has received a number of grants for research or clinical trials from organizations including the Alzheimer's Association, Brain Canada, the Canadian Institutes for Health Research, Calgary Health Foundation, the University Health Foundation, Public Health Agency of Canada, Hotchkiss Brain Institute, and the Canadian Consortium on Neurodegeneration and Aging. And then these are my disclosures. So as I said, the CCSMH guideline development honorarium. Oh, sorry, I'm just hearing some feedback. Oh, there we go. And then I received some funding from the Canadian Institutes of Health Research, St. Michael's Hospital Foundation, and Providence Healthcare Foundation. So we'd like to acknowledge our funding for this guideline. So this initiative has been made possible through a financial contribution from the Public Health Agency of Canada. The views expressed herein do not necessarily represent the views of the Public Health Agency of Canada. So these are our objectives for today's webinar. So really, this is actually our first time that we're sharing these clinical practice guidelines with anybody. So we're really excited to do this today and looking forward to your questions and comments. And then, of course, having said that, we want to ensure that everybody can understand the key topics and recommendations that we make today. So what are behavioral and psychological symptoms of dementia, otherwise known as BPSD? They actually, of course, as many of you here today know, probably also go by other names, and we'll talk about why we chose BPSD as the term that we're using today. BPSD are really those non-cognitive symptoms associated with dementia. There's a number of different symptoms. You know, we often think of symptoms like agitation or aggression, but there's other symptoms too that are really important, like depression, anxiety, apathy, eating disturbances, sleep disturbances, psychosis, you know, and so we're happy that we had the opportunity and this funding to be able to try and develop these recommendations. So as we said, BPSD is the term that we're using, but there's other terms that some people may be familiar with, such as responsive behaviors, reactive behaviors, or neuropsychiatric symptoms. And we know that these symptoms are very common in people with dementia. You know, published literature suggests that, you know, about 75% of people living in the community will experience a symptom of BPSD in any given month, and it's higher than that in long-term care setting, more than 80%. You know, I can say based on my personal experience, just a study that we just completed actually, every single person in our study had BPSD. In fact, on average, people had 3. So, you know, I think BPSD is something that really impacts caregivers and patients, and we really need to do our best to support them. And so why are BPSD important? So, you know, BPSD can be, you know, distressing to the person with dementia as well as their caregivers, both family and friend caregivers, but also, you know, the healthcare providers that are also trying to support them on their journey. And so, you know, BPSD are associated with functional decline and lower quality of life, increased risk of mortality, but also those health system outcomes as well, like increased risk of being admitted to long-term care and staying in hospital longer than other people who don't have dementia and BPSD. So how did we develop our clinical practice guideline? So here, just a brief overview. So we followed the Guideline International Network, otherwise known as GIN, McMaster Guideline Development Checklist, and we formed a guideline panel of people with research and clinical expertise from across Canada. We also had a number of expert external reviewers, including people with lived experience, who gave us feedback on our recommendations. It was a long, you know, process. We had about 18 months, and we used that time to do systematic reviews as well as rapid reviews, an overview of systematic reviews on BPSD to inform our guideline. And we've listed sort of the 6 different reviews that we did specifically to inform this work. we started first with a systematic review of existing guidelines that's now in press with JAMDA, which is the Journal of the American Medical Directors Association. And then that second point, that rapid overview of existing BPSD systematic reviews was really large. As you can see there, 294 systematic reviews. And that informed our recommendations that we'll be talking about here today. And then to fill in some of the gaps, where there wasn't a systematic review that we had identified, we did a rapid review of treatment strategies for sexual expressions of potential risk in dementia, and we did systematic review updates of tools for assessing anxiety and depressive symptoms, and then we did a systematic review of tools for assessing psychosis in people with dementia. And so here's the big team, everybody who contributed, and of course everybody at the CCSMH as well. But as I said, so myself and Dr. Seitz were the co-chairs. Dr. Stacy Hatch is a postdoctoral fellow who worked on this guideline as well. And then our research assistants include Ms. Jennifer Porter, as well as Patera Tavelsup, Kayla Atchison, and Pauline Wu. And then we had 3 people with lived experience, so Sonia Stepanoff, Linda Grossman, and Jory Warren. Then we had a number of students and trainees you can see listed here, and then we actually had 13 panel members as well. And our panel members represent a number of different health disciplines and specialists. You can see there's a pharmacist, a nurse, we have family physician representation, neurology, geriatric medicine, geriatric psychiatry, psychology, and pharmacology. And so back to the talking about the terminology and how we got to select our topics and outcomes for today. So we actually did an engagement survey with knowledge users from across the country, and we got 254 responses, including from people living with dementia and their caregivers, and again, a broad representation of health disciplines and healthcare providers more generally. And behavioral and psychological symptoms of dementia was the preferred term. Responsive behaviors was number 2, and neuropsychiatric symptoms was number 3. And so that's why we use the term BPSD throughout the guideline in our talk today. Then, in working with and as part of that survey, we also got people to do a prioritization of topics, and then we discussed those topics and potential outcomes with the guideline panel members, who then voted in terms of, what outcomes were most critical. And so that's how we arrived at the topics and outcomes that we'll talk about today. So we're going to be focusing on agitation, psychosis, depressive symptoms and depression, anxiety, sexual expressions of potential risk, as well as deprescribing. And so how did the guideline panel decide to make a strong or a conditional recommendation? So we followed then something called the GRADE framework for developing our recommendations, as well as for rating the quality of the evidence informing the recommendations, and then the strength of the recommendation. So generally, when we think about, what is a strong recommendation, and this was really the framework that guideline panel members had in mind when we were voting. A strong recommendation is something that most patients would want and most clinicians would advise their patients to have. And something that, policymakers, if they see a strong recommendation, this is something that they should act on. Versus whenever we talk about a conditional recommendation, it's something that we think like the majority, but not necessarily all patients would want. And again, the majority, but not necessarily all clinicians would advise their patients to have. And so, obviously we always advocate for shared decision-making and a thorough discussion of benefits and risks, but where we say that it's a conditional recommendation, more discussion may be needed just because it's not as certain as it would be for a strong recommendation. And certainly from a policymaking perspective, again, sort of more discussion, more debate is needed before implementing a conditional recommendation. And whenever we speak to the quality of evidence, there's a number of considerations that go into that, but certainly we look at, the studies themselves. We look at, what are the potential biases in the study and how could that have impacted the results. Importantly, in a number of characteristics from that perspective. But then, in addition to the quality of individual studies, whenever we're thinking about strong or conditional recommendation, we also have to consider, patient preferences and values, things like cost and feasibility of implementation, balancing the benefits and risks as well, and importantly, equity considerations, that we're not disadvantaging a group or advantaging another group because of a decision that we've made, or if we are doing that, making sure that we've carefully considered, why or why not that was an appropriate decision. And so now moving on to some of the actual recommendations. Now the other part to the grade framework that we need to discuss is that, in the grade framework, there are things called good practice statements, and then there are the actual recommendations. And so here, whenever we're talking about the general principles for assessing and managing BPSD, we're referring to good practice statements. And so these are things that, we didn't do, say, a systematic review to inform these, but these are sort of approaches and things that we think are part of good care that need to be done to support people with BPSD and their caregivers and the healthcare providers who are helping them. So first of all then, providing the education and resources needed to implement structured interdisciplinary approaches to assessing and managing BPSD, making sure that we're obtaining informed consent from the person living with dementia or from their substitute decision maker, any time that we're engaging in an assessment or developing a management plan. And again, the importance of making sure that we're considering the values and goals of care and prior expressed wishes of the person living with dementia. And then, making sure that we know about the person, what is the underlying cause of their dementia and how does that influence treatment decisions, what stage, are they in the mild, moderate, or severe stage of dementia, and then what are those specific BPSD that we're trying to treat. Oftentimes people will say, okay, they have BPSD or they have responsive behaviors, but then, when you dig into it, then you understand more. It's like, oh, they're having a lot of trouble, they're very anxious, or, they're really sad. And, so that's what we're trying to treat. And then making sure that we do a good thorough evaluation of the potential biological contributors. So, I'm a geriatrician, so making sure that, medically, I've tried to optimize this person's care and well-being as much as I can, making sure that we're understanding their personhood, and respecting their personhood, and then making sure that we understand the psychosocial and environmental considerations that need to go into supporting that person in their environment. And then making sure that we're always communicating with person-centered language that is sort of the preferred terms for the people who we're speaking with, and in a way that is understandable to everybody. And then, of course, we always recommend psychosocial interventions be part of a plan for treating someone's BPSD. Even if we're making a pharmacological recommendation, it should always be assumed that we're trying to maximize and optimize our implementation of psychosocial interventions. And then to make sure that we select and tailor the psychosocial interventions that we think are most likely to work for that person, which again gets back to, their personhood, who they are, what are the activities that they have enjoyed in their life and things that make them happy. And then routinely assessing the management plan and, adjusting that plan and revisiting it to make sure that it continues to be appropriate. And now I'm going to pass it over to Dr. Seitz.
Great, thanks so much. Is my audio okay?
Yeah, you're sounding nice and clear, but if you can just be cautious of your volume so you can speak up, that would be great.
Great, okay. Is that okay?
Yep, great.
Good, great. So yeah, so now we're going to kind of move on to some of the specific recommendations around assessing and managing BPSD. Our guideline was really focused on Alzheimer's disease and related dementias. So throughout the full guideline, you'll see specific reference to that. This is probably most important for the medication recommendations, but just to provide some context that when we're talking about dementia, we are talking about some specific common types of dementia here, not necessarily other types of dementia like dementia with Lewy bodies or frontotemporal dementia. And this is how our guideline recommendations have been sort of divided up across different topic areas here. So agitation, which I'm going to start with, has the most number of recommendations, certainly has the most extensive body of research. Psychosis, depression was our second largest topic area. That includes both symptoms of depression and a diagnosis of a depression or depressive disorder, and also topics related to anxiety, sexual expressions as well. Within these 5 topic areas, we provide recommendations around the preferred methods to sort of diagnose and assess it, and then non-pharmacological and pharmacological management. Deprescribing of medications follows a little bit of a different format because it's not a behavioral syndrome, and we developed 5 recommendations for deprescribing. Now I'm just going to sort of walk through at a very high level summarized recommendations. So these aren't the full text of the recommendations which are available in the guideline. So starting with assessing and managing agitation in dementia. In terms of diagnosis, our panel recommended the International Psychogeriatric Association's consensus criteria for agitation and cognitive disorders. This is sort of a standard approach to defining what is and isn't agitation that is being used more commonly now for research and to some extent in clinical practice. I do make note there is a dissenting opinion. All of the recommendations you're going to see here reached consensus, which is defined as at least 80% of the panel voting in favor. Most of our recommendations were actually unanimous decisions or unanimous agreement. However, there's a dissenting opinion from one member of the guideline panel who had some very thoughtful sort of comments and concerns about this, which have been included in the full guideline. In terms of detection and assessment, we have a number of tools that we recommend for assessing agitation. The Cohen-Mansfield Agitation Inventory is one that many people would be familiar with. There are other reading scales that are available. Also in the full guideline, there are some recommendations about tools that might be used for more general assessment of behaviors in dementia, things like the BSO-DOS as an example, which captures some behaviors which may be considered agitation, but also be other behavior changes that might be important. In terms of non-pharmacological management, these were the high-level recommendations where we felt like there was very strong evidence for. This doesn't necessarily mean there isn't evidence for other topics or approaches, but certainly interdisciplinary approaches to care, including education for team members, structured approaches to BPSD management, development of individualized care plans and meaningful activities is certainly one of the strongest recommendations with the best evidence for helping with agitation and dementia. There's a number of specific interventions also that had evidence, randomized controlled trial evidence, things like animal-assisted therapy and robotic pets, physical exercise, preferred music, massage, and aromatherapy. All of these had pretty reasonable evidence from a clinical trial perspective for symptoms of agitation. You'll also notice we didn't make any recommendations against any non-pharmacological approaches, but when it comes to medication recommendations, there are some areas where we've recommended against certain things because there was good evidence of them either not being effective or being risky. In terms of pharmacological management of agitation, our panel recommended that for moderate severity of agitation, and we've tried to define how do you distinguish between moderate and severe, that citalopram could be considered for treatment of moderate agitation. We didn't make a recommendation at this time for S-citalopram, which is a related antidepressant, because there's a large study that's underway, which will give us more information about this. In some circumstances, for severe agitation, citalopram could be considered, although it may not be the best option, except in some circumstances, which we expand on in the guidelines. For severe agitation, the agents and medications we've recommended are listed here in no particular order: aripiprazole, brexpiprazole, or risperidone. Any of those three could be considered a first-line treatment for severe agitation. If someone does not tolerate or respond to one of the medications listed as a first-line treatment, there could be a switch to another first-line treatment. However, we don't recommend switching from aripiprazole to brexpiprazole or vice versa, because they're quite similar. And while there haven't been a lot of head-to-head studies comparing aripiprazole and brexpiprazole, we felt that given they're so similar, if you didn't tolerate or respond to one of those, you're probably not going to respond to the other one, and so you may want to consider a switch to something different like risperidone if you hadn't been tried on that. For people who do not tolerate or respond to those initial treatments, we recommended quetiapine as a next option, and particularly if someone developed Parkinsonian symptoms with one of the first-line agents, quetiapine might be a reasonable agent. There's actually fairly reasonable evidence for low doses of older antipsychotics. So we did provide a recommendation. These actually can be quite effective for agitation, although they don't tend to be tolerated as well as some of the newer agents. So it was listed as a third-line treatment after other treatments that have been ineffective. And then for people who may not have responded to the previous treatments listed, two other medications that could be considered, which included nabilone, which is a cannabinoid, synthetic cannabinoid, and carbamazepine, which is a anticonvulsant medication. In terms of emergency treatment of acute agitation, we recommended short-term, short-acting antipsychotic that would be available in oral or intramuscular format. And this is really in an emergency sort of code white situation for a treatment of acute agitation. And if for some reason someone wasn't able to receive an antipsychotic, that we would recommend short-acting benzodiazepine. Number of medications we recommended against using where they've either been shown to be ineffective or have side effects. So cognitive enhancers, we don't recommend starting those for the treatment of moderate to severe agitation. We've recommended against olanzapine because it is less effective and has a highest side effect profile. There's a number of antidepressants that are commonly used to try and help with agitation that have actually shown to not be effective, including medications like trazodone, mirtazapine, sertraline, fluoxetine. So we've generally recommended against using these medications, as well as other antidepressants, which because of tolerability or side effect risk should not be used. Valproic acid also has strong evidence against its use. It's been well studied and shown to be ineffective and also can cause significant side effects. And we also recommend against the routine use of polypharmacy or long-acting or depot injection antipsychotics unless there's a reason for another reason for the person to be on a depot antipsychotic, such as a history of schizophrenia or a serious mental illness. There was one medication that is a little bit uncertain as to whether it could or couldn't be used, which is prazosin, and so we didn't provide a recommendation for or against using it. And a couple other recommendations. Electroconvulsive therapy sometimes is recommended for severe agitation. The quality of evidence at this point is pretty low, and so we didn't recommend for or against it. We did recommend against the use of seclusion or restraint except in specialized facilities on an emergency basis, but generally, again, recommending against seclusion and restraint, and provided some guidance around duration of treatment to ensure that both a therapeutic trial is given for medication, but also that people aren't treated sort of unnecessarily with medications that maybe aren't helpful for their symptoms. So in terms of recommendations for psychosis in dementia, we had less recommendations on this topic just because the evidence base isn't quite as extensive. There are some standardized criteria now recommended for psychosis in dementia or major neurocognitive disorders that we recommended. One assessment tool for detecting and measuring symptoms of psychosis using the neuropsychiatric inventory. Surprisingly, there wasn't a lot of primary research on non-pharmacological management of psychosis. However, a lot of studies that looked at non-pharmacological treatments will often report general changes in BPSD, using scales that measure multiple BPSD, but they don't always tease out the psychotic symptoms. There was one study we came across that looked at sort of a multi-component intervention for people in nursing home settings who had psychotic symptoms of BPSD, which included many of the elements of interdisciplinary care, education, care plans, standardized assessments, and they also included a number of meaningful and pleasant activities like art-based therapy and music as part of this. So our recommendation is that for psychosocial approaches that we've seen to be effective for agitation and other BPSD, that those could be considered for symptoms of psychosis. And in terms of medication management, it's actually very similar to the recommendations for agitation, where there's some evidence for citalopram helping with symptoms of psychosis for moderate psychosis, and for people who have more severe psychosis, aripiprazole or risperidone could be considered. We also acknowledge that given the limited number of studies, at times people with refractory psychosis in Alzheimer's disease may need to be tried on other medications as well, given the the limited number of medications that have actually been studied for this. Moving on to depressive symptoms and depression in dementia, we've provided separate recommendations on management for depressive symptoms and depressive disorder, or what would be akin to a major depressive disorder in dementia. And so we tried to tease those out because the evidence is a bit different for the two categories of depression. So for diagnosis of depression, we recommend the Depression in Alzheimer's Disease criteria developed by the National Institutes of Mental Health. And for assessment of depression, we recommend the Cornell scale for depression in dementia. I think this is a commonly used scale that probably many people are already familiar with. For depressive symptoms, there's a number of interventions here. Again, we see interdisciplinary approaches to dementia care, sort of not the same studies necessarily, but following the same approach that we saw were effective for agitation. Education around dementia, standardized assessment, individualized care plans are effective for reducing depressive symptoms. Cognitive stimulation, using very specific interventions for cognitive stimulation. reminiscence therapy, sort of engaging people in activities that taps into their interests and background, occupational therapy approaches to enhance independence or reduce, frustration with difficulties people might be having with cognition and functioning, exercise, and then also some evidence for some things that we saw were recommended in agitation, like animal-assisted therapy, robotic pets, and massage and touch therapy. For a diagnosis of depression, there were a few approaches that are really sort of psychotherapy-based approaches, particularly for people with mild to moderate dementia or mild to moderate severity of dementia. Both of these approaches really take sort of a problem-focused approach, and it involves family members or carers in the implementation of the approaches. But some good evidence that adapted psychotherapeutic approaches can be effective for treating a diagnosis of depression in dementia. And in terms of pharmacological treatment, in terms of depressive symptoms that don't meet the threshold for a diagnosis of a depressive disorder, we recommend against pharmacological treatments for people who do not have a concurrent diagnosis of depression. A number of medications have been studied to try and reduce symptoms of depression. They haven't been shown to be, any haven't been shown to be effective consistently, and plus they are associated with side effects. This actually is not that dissimilar from most guidelines that speak to depression management in people who don't have dementia, where it's really recommended not to use medications by and large unless people have a diagnosis of major depression. For those people who do have a diagnosis of depression in dementia, we recommend antidepressants for moderate to severe depression that hasn't responded to psychosocial approaches, using antidepressants that are recommended for the treatment of major depression in older adults. And so we make a reference back to the CCSMH depression guidelines, which recommend medications like sertraline and duloxetine as potential options. Recommendations around anxiety. Anxiety, actually, there aren't any standardized criteria for diagnosing anxiety disorders in dementia. So we recommend using standard criteria like you would see in the Diagnostic and Statistical Manual for conditions like generalized anxiety disorder. There is one scale that's frequently used to measure anxiety in dementia called the RAID, Rating Anxiety in Dementia for Detection of Anxiety. In terms of non-pharmacological management, education and training programs for family caregivers have been shown to be effective. This is teaching, typically teaching family members how to help identify triggers for anxiety, along with relaxation strategies to help support the person living with dementia. Also some evidence, again, for adapted psychotherapies, cognitive behavioral therapy with a significant behavioral component involving relaxation, incorporating caregivers, and some evidence for preferred music as well. And again, it's not to say other things don't work for anxiety, but this is where we have evidence. And in terms of pharmacological treatment, the one medication that had some evidence for this was citalopram. However, we also recommend that for people living with dementia who may have significant anxiety, that our CCSMH anxiety guidelines could also be consulted for other options that may be considered. And our last sort of syndrome topic area was what we referred to as sexual expressions of potential risk. Again, there wasn't any standardized definition for this that's been widely accepted. There's several very good ones that are out there. And so we provided a recommendation about how to define this as a destructive vocal or physical act of a explicit sexual nature or implied sexual nature, which is either intrusive or engaged in without the consent of the person living with dementia. So this is, trying not to pathologize normal, affection or normal expressions of sexual behaviors, but really, focusing on behaviors that are, pose some risk for, the person around the person living with dementia. There's one tool we recommended for assessing and monitoring these behaviors, the St. Andrews Sexual Behavior Assessment Scale. In terms of non-pharmacological management, this is an area where we probably also need some more research, but some recommendations that strategies such as, education, this is probably the big one, educating the people around the person with dementia, removing environmental triggers that might sort of reinforce sexual behaviors, changing the environment, or engaging people living with dementia in other activities are some strategies that, may be helpful in reducing some of these behaviors. In terms of medications, there's really limited evidence for any medication reducing behavior. Certainly things like antidepressants, some hormonal treatments have been studied in case series or very small open label studies. Our guideline does provide a very high level overview of the types of medications that have been studied, but given the potential side effects and very limited evidence, we really don't recommend for or against any specific pharmacological treatment for sexual expressions of potential risk. And now just transitioning on to our last group of recommendations on deprescribing of medications. Sometimes people get started on antipsychotics or other medications for BPSD for reasons that really aren't appropriate or for indications that are not appropriate. And so we made a recommendation that if antipsychotics were started in a person with dementia who don't have a history of severe agitation, psychosis, or another appropriate indication for an antipsychotic, such as other mental health conditions like schizophrenia or depression, that these medications should probably not be continued. It's not always easy to know why a medication was started, but if there isn't a clear indication that this medication should have been started in the first place, that's probably a good place to sort of focus in on trying to reduce and discontinue the medication. The second recommendation is to try to provide a little bit of nuance about the things that should be considered when you're working through who or how to discontinue antipsychotics in people that perhaps did have severe agitation or psychosis, but perhaps are not exhibiting those symptoms now. So when considering whether to stop antipsychotics, you should consider, the current symptoms. Obviously you don't want to stop medications in someone who's had severe BPSD now, or it may not be the best candidate. How long they've been treated. The longer someone's been treated and stable, the more likely they are to successfully come off. The dose of medication, people who are on higher doses tend to be at higher risk for having behaviors worsen if you take them off, and the initial severity of symptoms. So these are some of the key things that need to be reviewed when considering deprescribing of antipsychotics. And if a decision is made that it may be appropriate to try deprescribing, would recommend that's done very slowly, 25 to 50% reduction in dose every 1 to 2 weeks. And if we start to see behaviors worsen, to stop at the lowest dose that stabilizes the behaviors. Other recommendations related to deprescribing is to review other medications for discontinuation, to to determine if they're not needed, like things like benzodiazepines and antidepressants, both of which can be prescribed pretty regularly and should also be reviewed to see if they're required. And we also provided a recommendation about some strategies to help support deprescribing at a facility level, which includes having structured medication reviews, pharmacist-led reviews, education on family physicians and other prescribers in long-term care to facilitate routine monitoring and deprescribing in clinical settings. So in summary, hopefully our guidelines will provide evidence-based recommendations for BPSD. We're going to be updating some prescribing resources to accompany the guideline in the next few months. We're planning a BPSD echo in the fall of 24, and there's some possible updates and expansion of the guidelines in the future. There's some topics like sleep, apathy, caregiver support, which we would have loved to include here, but just given the timelines, we were unable to include them in the current guidelines. Also, an amazing resource that Nick Ubels and the team at CCSMH has put together. There's lots of great practical resources for clinicians and family members related to behaviors on the Behaviors in Dementia Toolkit website. So certainly if you want some practical tips and strategies for the recommendations that we've talked about, this is a great resource for people to go to. And also encourage all of you to join the CCSMH if you aren't already a member, and to keep an eye on our website for resources related to BPSD in all of our topic areas. So I think I'll wrap up there, and maybe we can go to questions.
Great. Yes, thank you so much, Dallas. All right, we've already had some great questions coming in, but for those who aren't sure how to ask, you can just ask your question in the Type Here box on the very bottom of that Q&A box, and we will get to as many as we can for the time remaining. I do want to note also that we do have some poll questions that will be coming up in the last 5 minutes or so. So we do invite you to take part in those before you leave the webinar at the end of the webinar, because your feedback is certainly important to us, and so we ask that you take part in that as well. But let us get to the questions first with the time we have remaining. So let's get started, I think, with a question that's come up a couple of times already, Dr. Seitz, and that is, and Dr. Watt as well. So I'll invite you both to speak to this. But in terms of the panel and the contributors, it was noted a few times by participants that it seemed to weigh heavily towards physicians versus nurses, PSWs, allied health team members, perhaps even care partners, and that those individuals, particularly the professionals, are usually the first in line who are working with people living with a cognitive impairment and experiencing responsive behaviors. And so this individual says that they're concerned that the guidelines have limited applicability outside of situations with significant physician or specialist involvement because of the lack of the representation of other valuable members of the care team. So they were wondering if you would be open to commenting as to why perhaps other team members were not included in the panel when developing these guidelines.
Yeah, so it's a great comment. I would say there's probably a couple reasons for that. So in terms of the composition of the panel, in addition to like geography and setting, there's also considerations around say things like alignment with other guidelines and organizations developing guidelines to ensure we have sort of representation and alignment with other organizations, and it is heavily weighted towards medical clinicians. I think where we tried to bolster perspectives from outside, those perspectives were our external reviewers, where we did have additional nursing staff provide feedback, psychology. We had 3 members with lived experience, provide feedback on the sort of external review as well, and then preceding the guideline being, panel being struck and the topics being selected, we'd also had done a number of surveys which were actually included, I would say, more respondents from outside of medical participants, or there was much more representation in the survey, which is what we use to guide our topics and selection of questions. So yeah, I think it's a fair comment, and we've tried to round out the opinions and recommendations. The other, I'd say, challenge with this, it's such a big topic, and also, as Dr. Watt mentioned, there's 295 systematic reviews of existing research on the topic, and so we really we didn't want to exclude evidence from other areas, but we also had so much evidence from systematic reviews, or like high quality evidence, and so many recommendations already. We really wanted to at least focus in on the areas where we have the strongest, evidence base for research. And so that was part of the decision around, what did make it into recommendations and what didn't, which was, focusing in on where we have the strongest evidence to date, and highlighting some areas where we don't have as strong of evidence, where we need to generate, the evidence.
Thank you. Just to go a little bit further, and then we'll move on to other questions as well, but I'm trying to incorporate a couple in the questions that I asked. When the guidelines seem to differ from some of the work that's being done by a lot of educators within the various sectors, who really try to, or seem to, we've been I guess, engage in the process of avoiding the use of certain labels, like, for instance, agitation. In everyday clinical practice, that's not used in the same way as it's used in research necessarily, or by physicians. So again, sort of posing the question as to where the decision was made that to go against, I guess, if, for lack of a better term, the main education curriculum that's associated with GPA and pieces, UFirst, and that sort of thing, that tend not to use that same language that's used in these particular guidelines, and defer to other approaches like exercise and environment, and speaking to how those play a significant role as well.
Yeah, I mean, the topic around language is so, challenging. And I think, our reviewer colleague from the Alzheimer's Society of Canada provided a very good comment, which is incorporated in the guideline, is, probably what's most important is to use a language that's preferred, by the person living with dementia or their family member, and that isn't, I would say, widely agreed upon. So I think we're trying to have some common language and terminology, while acknowledging that there's different usages of the language. BPSD, still is the most commonly used terminology for sort of overall symptoms internationally. It was the preferred term identified by caregivers in our survey. It's not the preferred term by all caregivers or persons living with dementia, but it actually was in the survey that we conducted. And I think part of the interest or emphasis on trying to define behaviors a little bit more granularly with specific criteria is we actually have evidence that certain interventions, particularly on the medication side, only work for certain types of behaviors. I think on the non-pharmacological side, we see the same themes popping up across different types of symptoms. The label may be a little less important there than having a general approach, but for the medication standpoint, I think it is important to have, some very specific criteria. And agitation is the term that's been used to, very specifically define what is and isn't agitation using the IPA criteria that we've recommended. So, I'll say it's a compromised position, with the terminology that we tried to address as best we can. In the guideline, we acknowledge, different people use different terminology, and no terminology is accepted by every group of providers or people living with dementia and carers.
Okay. Thank you. I'm cautious of time, so I'm going to jump right into some other questions. These are in particular having to do with some of the pharmacological recommendations that you've made within the guidelines. This was in specific reference, I believe, to agitation and the use of citalopram. Was the very low quality of some therapeutic modalities due to not enough research or poor correlations?
I would say, there's a lot of studies on pharmacological treatments for agitation, and the limited quality sort of reflects, a couple things. So one is like strong versus conditional. To have a strong recommendation, you basically have to say, everyone with this condition would want this treatment, and I think that's like very hard to find for a lot of our medications. There's a lot of preferences and differences in values and risks and benefits, and uncertainty, about safety and efficacy about the medications. But certainly all the medications that we've recommended, in there have like reasonable quality of evidence to indicate there can be some benefit. With the medications, it's balanced against the risks of the medication, which make it hard to apply, across every individual who's living with dementia. Mm-hmm. But, we do have quite a bit of research that, related to pharmacological treatments, including, medications that have now been, like, whether you agree with it or not, Health Canada approved for agitation in dementia.
And
I know, Jennifer, if you have any questions.
I was just going to say, Jennifer, if you have any comments, I don't want to not include you in this conversation, certainly.
Oh, no. Dr. Dallas has been doing a great job. I don't have anything to add right now.
Okay. Further up to that conversation regarding citalopram, like another question that has popped up here is whether there's any particular reason for recommending citalopram among other SSRIs for anxiety and agitations. This is a geriatrician that's speaking who has used sertraline, sorry if I'm mispronouncing that, on their patients with great benefits.
Yeah, so I think like citalopram was the one medication that does have some evidence, like it's actually been shown to reduce symptoms of anxiety. We recognize that other medications, other SSRIs, like sertraline or, dual acting agents like duloxetine might also be effective, which is why we've said for significant symptoms of anxiety, citalopram might be a first option to consider, but other medications listed in the guidelines, the anxiety disorder guidelines could be considered. I would say the evidence for sertraline for agitation in dementia is pretty good that it doesn't work, even though it's used pretty frequently. If we look at the meta-analysis, the effect size for sertraline is 0.08, which is like zero. Like there's no, and it's not because it hasn't been studied. It's been studied in several studies. So it doesn't seem to be effective. The evidence we have right now doesn't seem to show that sertraline is effective for agitation compared to citalopram, which has an effect size of around like 0.3, which is, a small effect versus like basically no effect with sertraline for agitation. Depression and anxiety is a little different for the other antidepressants, which is why we also didn't recommend against other antidepressants for depression and anxiety.
I recognize that we're at the 1 o'clock, and so I'm going to try to squeeze in one more question here because it's a slightly different one that's been addressed thus far. And that is, how do you foresee or do you foresee these guidelines influencing the ministry standards or expectations with respect to inspections of long-term care homes and best practices within long-term care homes?
Well, I certainly, and our panel sort of also struggled with this, that which is why we have the recommendation around organizations being provided with the resources and supports they need to be able to implement these guidelines, because we certainly don't want the guidelines to be well, it says you need to have pet therapy and exercise and music available to everyone. What are you doing about that when they're not being provided with the resources? So our hope is that our guidelines will help identify for our funding partners and policymakers the resources that are going to be required to implement best practices for non-pharmacological management of behaviors, because the reason why people aren't employing these recommendations, some of it may be lack of knowledge, but I think in most settings it's lack of resources, which needs to come from our health ministries to provide those resources to enable best practices in long-term care, particularly in not just, but particularly in long-term care.
Excellent. Well, I'm afraid we're going to have to leave it at that. I'm looking at the time, so unfortunately we're going to have to end it here. Apologies for not getting to everyone's questions. I know that there was a lot that weren't able to be addressed during the time that we had, but I do thank you for your engagement and your participation. A brief reminder that you will have access to both the slides from today's presentation as well as the guidelines themselves on Brain Exchange under our archived events section in the near future. You can see the link there for the slides as well online. And when ready, the recording as well as the slides and the link to the guidelines will be sent to your inbox directly. So you can go from there as well. So with that in mind, I do want to thank our presenters today, Dr. Dallas Seitz, Dr. Jennifer Watt. Thank you so much for sharing your time and insight and expertise, particularly with respect to these new guidelines. Much appreciated. And again, thank you everyone for joining us this afternoon or this morning, wherever you are. So have a great day, everyone, and we'll go from there. Take care, everyone. Bye-bye.